Okay, let's unpack this. If you're listening right now, you are officially in high-yield survival mode. You've learned the content, you've sat through the lectures, you've done the readings, you have all the raw information.
Right.
But the final exam, especially when it comes to pediatrics, is not about rote memorization. It's all about pattern recognition and clinical prioritization.
Exactly. Our mission today is total concept consolidation built specifically for that final push. We are running a compressed, high-intensity review covering pediatric growth and development, assessment principles, and, the key strategies for age-appropriate care.
And we're really synthesizing those big theories, right? Erickson and Piaget?
Yes, and applying them directly to the what-if clinical scenarios, and critically, the sneaky NCLEX traps that examiners use to test your reasoning.
Think of this as a shortcut to being well-informed for those high-stakes questions. We are moving quickly through the essential patterns, hallmarks, and red flags drawn directly from your core material.
And to make this review stick and aid rapid recall, we'll analyze each age group by asking 4 critical questions.
Okay, what are they?
What is the hallmark developmental pattern? What is the priority nursing action or health promotion strategy? What's the classic NCLEX trap associated with this age?
And the last one.
And finally, what is the single sticky memory anchor you can hold on to?
I like that. We need to go beyond just, listing milestones. We're going to discuss why certain behaviors, like a toddler's tantrum or an infant separation anxiety, are actually clinical indicators of normal developmental progress.
Not poor behavior. Understanding the why unlocks the prioritization on the exam. So let's not waste a second. Let's jump right into the foundation. The infant.
Okay, let's do it. The infant, 0 to 12 months.
This is the period of explosive, almost nonlinear growth.
You must know these numbers cold because they are the foundation for any nutritional assessment. So birth weight doubles by 6 months and triples by 1 year. If you see a failure to hit those milestones on an exam, that is an immediate nutritional red flag that warrants investigation.
And the length trajectory is equally rapid. Length increases by about 50% by 1 year.
Beyond the anthropometrics, assessment centers heavily on those directional trends we all learn.
Cephalocaudal and proxima distal.
Physical control moves cephalocaudal so, head control before trunk control, and proxima distal central arm movement before that fine finger control.
And speaking of physical assessment, let's lock down the fontanelles. This is such a common test question.
It is. They use it to gauge your understanding of head trauma, hydration status, neurological health, everything.
Remember, the posterior fontanelle is the early closer. It typically fuses completely by about 2 months of age.
Critically, though, the anterior fontanelle is the late closer. That one stays open up until 12 to 18 months.
Which is important because if it closes too early, that's a concern for brain growth restriction.
And if it's bulging?
A potential sign of increased intracranial pressure. If it's sunken, that immediately points to dehydration.
And you have to track head circumference, too. It should equal the chest circumference by 1 year, which again links right back to neurological growth.
Okay, so motor development. This is a sequence of achievements leading to mobility and control.
The ability to sit unsupported, that's usually around 7 to 8 months. But the truly high-yield motor skill for fine control is the pincer grasp.
Achieved around 9 months, yeah.
That transition from just raking things to grasping with the thumb and forefinger, it dictates when they can start to self-feed small pieces of food.
And then walking follows that, around 1 year, though the normal range does extend up to about 15 months.
Okay, so theoretically, where are we?
We are in Erickson's phase of trust versus mistrust. Trust is developed when basic needs, feeding, comfort, stimulation, are met consistently and predictably.
And if they're not?
If needs are ignored or met erratically, that's where mistrust develops.
And for PHS?
That's the sensorimotor stage. Infants are learning entirely through their senses and manipulating objects.
And the key cognitive acquisition here is massive. Object permanence.
Huge. It develops around 9 to 10 months. This means the infant now knows an object or a person exists even when it's out of sight.
Why is that important clinically?
Because that cognitive leap directly explains the sudden appearance of separation anxiety, which starts around 4 to 8 months and really peaks around 11 to 12 months.
And stranger fear, too.
And stranger fear, which starts around 6 to 8 months. Misinterpreting this normal anxiety as poor coping or some kind of issue is the classic mistake.
So these behaviors are actually evidence of successful cognitive growth.
Exactly. They know you exist when you're gone, and they can differentiate familiar from unfamiliar faces.
And what about play for this age?
Simple, focused, and alone. Solitary play.
Okay, so beyond the growth charts, the primary red flags in the infant stage scream either neurological delay or an unsafe environment.
Right. Failure to meet those doubling and tripling weight rules, coupled with persistent poor feeding or lethargy, is always a major nutritional and metabolic red flag.
And the neurological red flag you have to watch for.
Persistent head lag after 6 months. Remember, development moves cephalocaudal. By 6 months, they should have full head control.
So lack of control would indicate what?
Potential hypotonia, or a neurological issue that demands immediate follow-up, probably with a Denver dissecus screening.
Let's talk immediate safety crisis, because this is where the exam loves to test prioritization.
And the number one is no propped bottles.
It seems so simple, but this is a massive aspiration risk, especially if the infant falls asleep with the bottle.
And it's not just aspiration. The nearly horizontal and short eustachian tube of an infant allows fluid to easily back up into the middle ear, which contributes directly to frequent otitis media.
Good point. Another clinical check is immunizations. You need to lock down the pattern for that core cluster that starts at 2 months.
DT, RV for rotavirus, IPV for polio, Hib, PCV, and Hep B.
Knowing that cluster allows you to check if the child is current and ready for school later on.
So if you only remember one thing about the infant psychosocial stage, remember the connection. Trust is built on consistency.
And separation anxiety is evidence of object permanence.
Yes. So if a 10-month-old cries hysterically when mom leaves the room during a hospital assessment, the best nursing response is recognizing this as normal developmental progress.
Not something that needs sedation or punishment.
Exactly. The intervention is providing consistent care and maybe a transitional object.
Okay, priority actions. Let's talk nutrition.
It's tightly regulated for safety and optimal brain growth, so breast milk or formula only for the first 4 to 6 months.
And then we introduce solids, specifically iron-fortified cereal, when the infant can sit with support and the tongue extrusion reflex is gone.
Meaning they won't automatically push food back out of their mouth, usually around 4 to 6 months.
This brings us to the 2 required daily supplements you absolutely cannot miss on an exam.
First, vitamin D daily, from the first few days of life, regardless of feeding type. It's essential to prevent rickets.
And sunlight exposure isn't enough, and breast milk doesn't have enough.
Correct. Second, and this is the high-yield trap, iron supplementation is mandatory after 4 months if the infant is exclusively breastfed.
And why is that?
Because maternal iron stores, which were transferred during pregnancy, are typically depleted around 4 to 6 months, and breast milk iron content is pretty low.
Formula-fed infants usually get enough from the formula itself.
Right.
Safety-wise, the ultimate mandate is SIDS prevention. The exam loves to test compliance on this.
The core mandate. Always sleep on the back, supine. Use a firm mattress and eliminate all soft bedding, bumper pads, pillows, or any loose objects that pose a suffocation risk.
This is non-negotiable teaching.
And motor vehicle safety is also non-negotiable. It requires a rear-facing car seat in the back seat.
For the infant, the safest position in the back seat is the middle position, right? Away from side impact collisions.
That's the rule until they meet the height and weight limits of the seat, ideally past age 2.
Okay, let's run the traps specific to infant care. A very common one is confusing the fontanel closure timing.
If the question asks which closes first, remember posterior P closes quickly, 2 months. If it asks which closure is delayed, remember the anterior A closes after 12, 18 months.
Another major trap is overlooking the iron supplementation rule for the breastfed infant after 4 months.
The scenario describes an exclusively breastfed 4-month-old, and there's an option for iron. That is the correct nutritional priority intervention.
And the psychological trap.
Misinterpreting that sudden increase in separation anxiety or stranger fear. It is not a sign of regression or maladjustment.
It's evidence of cognitive growth, the acquisition of object permanence.
So the correct intervention is reassurance and consistent presence, not trying to force sudden independence.
Finally, the safety violation trap. Choosing to give extra water to an infant under 4 months.
Yeah, their immature renal system just cannot efficiently handle the solute load. It makes them prone to fluid imbalances, including water intoxication and dehydration risk,
If they're thirsty, they need formula or breast milk.
which are hypotonic and designed for their system. Never choose water for hydration in the first 4 months unless medically indicated.
Okay, memory anchor.
Lock this in. Infant. Trust me, I'm tripling my weight, developing object permanence, and I need vitamin D and iron.
All right, moving into the toddler phase, 1 to 3 years. This is a dramatic change of pace.
It really is. Physical growth slows way down compared to the velocity of infancy, which eases a lot of parental worry about constant calorie intake.
They're gaining a modest 4 to 6 pounds per year, and they should quadruple their birth weight by about 2.5 years.
And in terms of height, this is where we start making adult projections.
Right, that key assessment rule is that the child often reaches their adult height projection by doubling their height at 2 years. This helps track expected developmental outcomes.
And physically, their proportions change. The chest circumference now exceeds the head circumference.
And you see that classic physical appearance, the pot-bellied squat.
A hallmark due to weak abdominal muscles and slightly short, often bowed legs, giving them that unsteady gait.
Cognitively, they're making a major transition out of sensoromotor and into the beginning of the pre-operational stage.
Specifically, the preconceptual phase. They start understanding basic cause and effect and spatial relationships, but they are still highly concrete.
They can't deal with abstract thought or see situations from another person's point of view. That's their primary limitation.
Psychosocially, this is the era of Erikson's autonomy versus shame and doubt.
The phase of fierce independence.
The drive for control over their body and environment is paramount, and it manifests in two hallmark behaviors: negativism, no, and extreme ritualism.
They need that consistency in routine food, bedtime, clothing to support their sense of control and predictability.
And failure to achieve that control, or shaming them when they fail to achieve it, especially around toileting, directly leads to the negative outcome: shame and doubt.
Motor control is also essential here. The myelination of the spinal cord is typically complete by 2 years.
Which is the underlying physiological requirement for voluntary sphincter control, the potential for bladder and bowel control.
And their play reflects this. They transition from solitary to parallel play.
Meaning they play side by side, sometimes using the same materials, but they are fundamentally playing separately. They don't share a common goal or interact significantly.
Okay, so the hallmark behaviors are often challenging for parents, but they're developmentally normal.
Constant temper tantrums, which are usually explosive reactions to blocked autonomy or frustration because their verbal skills lag way behind their desires.
And that intense need for ritualism must be respected to maintain their sense of control.
Nutrition is tricky here because of that slowed growth rate. They exhibit what we call physiologic anorexia.
Their appetite naturally decreases because they aren't growing as rapidly. This is normal and not a sign of true nutritional deficiency, but it often causes parents a ton of anxiety.
So if a parent calls worried about a toddler not eating enough, the nursing response should be one of reassurance.
Explain the metabolic shift, emphasize that snacks should be nutrient-dense, and stress the importance of small portions.
Right, remember the rule. 1 tablespoon of solid food per year of age. They do not need the same volume they consumed as infants.
The major safety red flag here is unequivocally choking risk.
Absolutely. Because they are mobile and still learning to chew, high-risk choking foods have to be eliminated. Whole grapes, hard candy, nuts, popcorn, and circular foods like hot dogs.
Or thick, sticky peanut butter.
Language acquisition just explodes. By 24 months, they often have a vocabulary of 400 words and use 2 to 3 word phrases.
Which we call telegraphic speech, right? Like, want cookie now.
Exactly.
Yeah.
Failure to achieve 50 words by 18 months or use 2-word phrases by 24 months is a crucial red flag for language delay.
So if you only remember one thing about the toddler stage,
Is that autonomy is everything. Ritualism, negativism, tantrums, they're all manifestations of this drive. When you are assessing an intervention, ask, does this choice support safe autonomy or does it restrict it and cause shame?
Okay, so priority nursing actions. Discipline.
Principals must reinforce boundaries while supporting that autonomy. Timeouts are appropriate starting at 18 months, but the key is the dosage.
Use the rule of 1 minute per year of age, no more, no less, and in a neutral, non-stimulating environment. This teaches self-regulation without shaming.
In terms of feeding, we need to transition away from the high-fat needs of infancy. So switch to low-fat milk after 2 years and limit intake to 16 to 24 ounces a day to prevent milk anemia.
And critically, they need to be weaned off the bottle completely by 15 months to protect against early childhood dental caries.
Always encourage safe self-feeding. It's a core act of autonomy.
Injury prevention in the home focuses on their new mobility and curiosity.
All poisons, cleaners, medications must be locked away. And because of their low center of gravity and curiosity, they're vulnerable to drowning in very small amounts of water.
Toilet lids must be closed.
Car seat safety dictates they stay rear-facing until at least 2 years. or until they max out the weight and height limits of the seat. Then they transition to a forward-facing seat with a 5-point harness in the back.
Turning them forward-facing too soon is a major safety violation in an exam scenario.
Okay, let's talk traps. The primary trap relates right back to Erickson. The exam will present a scenario where a toddler is having accidents while toilet training or refusing food ritualistically.
Track 1.
The wrong response is shaming the child, forcing compliance, or restricting safe opportunities for independence. The correct response is always supportive redirection and minimizing the reaction to accidents.
To preserve autonomy and prevent shame and doubt.
Exactly. Trap 2. Confusing their egocentric view, their inability to see from another person's perspective, with selfishness. They are preconceptual. They genuinely cannot understand sharing in the way an older child does.
So you teach sharing through simple, concrete terms, but you don't punish the egocentrism.
Right. It's a stage they have to grow out of. Trap 3. Trying to radically change their diet or routine because of that physiologic anorexia. Consistency and respecting ritualism is often more essential for a toddler's psychosocial health than the nutritional content of any single meal.
Offer choices, but keep the routine stable.
And trap 4. Forgetting the clinical relevance of myelination completion at 24 months. If the question involves toileting, the physical prerequisite, the potential for sphincter control, is tied to that myelin sheath completing its work. That's the physiologic go-ahead signal.
Okay, the memory anchor for the toddler.
Lock this in. Toddler. Autonomy means no. Potbelly, parallel play, and respecting their rituals.
Moving to the preschooler stage, 3 to 6 years. Physical growth stabilizes even further.
Yeah, a steady gain of about 4.5 to 6.5 pounds per year. The pot-bellied appearance fades as their abdominal muscles strengthen and they get leaner and taller.
And gross motor skills are mastered. They run well, climb stairs easily, ride tricycles. They're highly active.
Cognitively, they remain firmly in the preoperational stage, but they're transitioning to the intuitive phase, which is ages 4 to 7.
This stage is dominated by imagination and highly specific cognitive limitations that you have to recognize on the exam.
Key features include magical thinking. They believe their thoughts are all-powerful. Animism. They believe inanimate objects have feelings, which makes simple procedures like injections scary for the doll.
And the critical concept of centration.
Centration means they can only focus on one aspect of a situation at a time. This has massive implications for teaching and patient instructions.
So if you give them multi-step instructions, first, sit on the bed, then hold this cup and wait for the nurse. They'll focus on one aspect and likely fail the others.
You have to break instructions into single, clear steps.
Erickson's task here is initiative versus guilt.
They're energetic learners who want to try new things, start projects, and mimic adult roles. They gain pleasure from mastering skills.
And guilt results if they feel they've misbehaved, if they fail tasks beyond their capabilities, or, and this is key, if they feel their thoughts caused harm.
Their morality, per Kohlberg, is still pre-conventional, pre-moral. Actions are judged solely based on the external reward or punishment they receive.
They understand rules, but only as a means to avoid trouble.
And play transitions again. This is the era of associative play.
So they play in loose groups, in a common location using shared equipment, but, and this is the key difference, they have no rigid defined rules or shared common goal.
They're basically doing parallel play in a group.
Okay, hallmarks and red flags. The hallmark behaviors relate directly to that imagination. Their concepts of time are related to daily events, like we'll do that after we watch cartoons.
Language is expansive. They move from 3 to 4-word phrases to complex sentences. This is the why and how stage.
A major developmental issue the exam often addresses is lying.
When a preschooler lies, it's often driven by their powerful imagination, confusing fantasy with reality, or, most critically, fear of punishment.
So the priority nursing action is never to immediately punish.
No, you first explore the cause and reassure them that their imagination or their fear is understood.
In the hospital, because of animism, they have intense fears related to body integrity. They fear objects and instruments like the blood pressure cuff because they believe they're alive and malicious.
Which is why using medical play, allowing them to act out the procedure on a doll, is such a critical intervention for this age group to address those fears.
And their concept of death?
They view it as a temporary event, or sometimes related to that magical thinking, a punishment for misbehavior or for wishing someone ill. This just reinforces the need to address guilt immediately.
So priority actions. Discipline needs to focus on setting clear, achievable limits, that foster initiative.
They need activities that allow them to feel successful without being overwhelmed, which reduces the likelihood of generating guilt from failure.
Injury prevention shifts slightly toward teaching rules and external protection.
Water heater temperatures must be set less than 49 degrees Celsius or 120 Fahrenheit to prevent scald burns. In the car, they transition from a harness seat to a booster seat, which is required until they reach 4 feet 9 inches.
And teaching pedestrian safety is critical now, too.
The most essential, high-yield NCLEX intervention related to magical thinking is addressing that guilt.
So if a scenario involves a child saying, "I wish my sister would fall, and now she did,"
the nursing priority is immediate, emphatic reassurance that thoughts or words cannot cause accidents or injury. You must dispel that guilt to maintain their psychological health.
All right, NCLEX trap defense. Trap 1.
Choosing to punish lying without first exploring the underlying cause, fear versus imagination. If the child is lying out of fear, punishing them just reinforces the guilt and drives them further into secrecy.
So the appropriate response is reflective listening and reducing the source of fear.
Trap 2. Underestimating centration. Giving multi-step complex instructions will likely result in failure. Break it down. Take your pill now. Good now. Put on your pajamas.
Trap 3. Misidentifying play. Associative play is not cooperative play.
Remember the distinction. Associative play lacks the structure, rigid rules, and shared goal that defines cooperative play, which we see in the next stage.
So if the group is loosely involved in dress-up, it's associative. If they're all working together to build a shared Lego castle with a plan, that's cooperative.
And trap 4. Assuming that medical play is just for distraction. For the preschooler, medical play is a therapeutic intervention that lets them process the perceived threat to body integrity and address the fear from animism.
Memory anchor for this one.
Lock this in. Preschool. Initiative means magical thinking, centration, and associative play.
Okay, let's group the final 2 stages. School age and adolescent from 6 to 18 plus years.
We group them because they represent that transition from mastering the world through doing to mastering the self through thinking.
Let's start with school age, 6 to 12.
This is the time of significant refinement. Erickson's task is industry versus inferiority. They need a sense of accomplishment, competence, and mastery from their skills and knowledge, be it academics, sports, or hobbies.
And failure to achieve those skills, or an excessive emphasis on competition that leads to repeated failure, results in inferiority.
Piaget is the concrete operations stage. This is a massive shift. They move from perceptual to conceptual thinking. They finally understand why things happen.
And the defining cognitive achievement is conquering the concept of conservation.
Understanding that mass, weight, and volume remain constant despite changes in appearance.
Play for the school-age child is the most advanced form, cooperative play.
Organized, defined rules, and a common goal. This is where team sports and structured board games become developmentally appropriate and really beneficial.
Okay, now the adolescent, 12 to 18 plus.
Erickson is identity versus role confusion. They experiment with different roles, values, and beliefs, heavily influenced by their peers, seeking a coherent sense of self.
And Piaget is the formal operations stage.
They achieve abstract and hypothetical thinking, using formal logic to solve complex problems and imagine future consequences.
You absolutely must know the pubertal sequences because they are primary biological milestones and indicators of endocrine health.
For girls, the order is 1. Breast development or thirarche, 2. Pubic hair, 3. Axillary hair, and 4. Menstruation or menarche.
And menarche typically follows breast bud development by about 2 years.
Correct. For boys, the sequence is 1. Testicular enlargement, that is the absolute first sign of puberty, 2. Pubic hair, 3. Penile enlargement, then axillary hair, facial hair, and finally voice change is the last physical marker.
Getting that initial sign correct for both genders is a frequent trap.
Yes, it is.
So hallmarks and red flags. The school-age hallmark is the need for visible achievement to build industry.
We want challenging but achievable tasks. They master the ability to see others' perspectives, which makes group work and moral development transition into the conventional stage. They obey rules for the sake of order, not just to avoid punishment.
Adolescence is defined by rapid growth, a high metabolic rate, and a profound need for privacy and peer belonging.
They often suffer from chronic sleep deprivation because of early school start times, coupled with their changing circadian rhythm, which naturally drives them toward later bedtimes. They need about 9 hours of sleep per night.
The major red flags in the adolescent period are heavily weighted toward mental health and high-risk behaviors.
You must screen annually for depression, anxiety, suicidal ideation, and substance use.
Warning signs that require priority intervention would be things like a new onset of poor school performance, social isolation.
Loss of interest in previously enjoyed activities and significant changes in appetite or sleep patterns.
Statistically, unintentional injuries are the leading cause of death in adolescents.
And motor vehicle accidents are the primary cause of mortality. This statistical fact has to drive all your safety teaching.
Focus on seatbelts, distraction from phones, and driving under the influence. This is a life or death prioritization.
Absolutely. So, priority nursing actions. Hospital care and patient teaching have to align perfectly with their cognitive stage.
For the school-aged child, in concrete operations, you give clear, concrete, step-by-step instructions. Use models, diagrams, or demonstrations. Do not use hypothetical explanations.
And always knock before entering the room to respect their growing need for privacy and bodily autonomy.
For the adolescent, in formal operations, you can and you must provide honest, abstract explanations about their condition, prognosis, and treatment risks. They can process formal logic.
Respect their privacy fiercely, and when teaching about chronic disease compliance, like for diabetes or CF, the most effective strategy is leveraging peer support and role models.
Teens who are successfully managing the condition. Peer acceptance is everything.
Immunization priorities around 11 to 12 years are Tdap booster, HPV, and the first dose of an SCWY, with that crucial second dose of an SCWY coming at 16 years.
Okay, let's hit the traps. Trap 1 for industry.
The test question might suggest a child keeps failing tasks. Inferiority results not just from failure, but also from situations that are inherently unfair or overly competitive. The safest action is providing structured activities that focus on skills, mastery, and visible achievement.
Like a certification or a skill badge that builds competence, rather than just focusing on winning a competition.
Exactly. Trap 2, a cognitive mismatch. This is highly tested.
If you have a school-age child and the answered choice involves using hypothetical scenarios or abstract language, it's the wrong answer. They need the concrete.
Conversely, if you have an adolescent and the answer choice involves overly simplified concrete models, that's also wrong. They may feel patronized.
Trap 3, safety.
Failing to screen for depression, SI, or substance use in any adolescent presenting with vague complaints like chronic fatigue or headaches. Given that unintentional injury is the leading killer, addressing mental health precursors is a mandatory clinical priority. Never ignore those symptoms.
And trap 4, puberty.
Confusing the initial signs. Girls start with breast buds, ortholarche. Boys start with testicular enlargement. Lock down that order. It's the benchmark for normal pubertal timing.
Okay, memory anchor.
Lock this in. Adolescent. Identity is abstract, hormonal, demands privacy, and prioritizes peer influence.
All right, we've cemented the age-specific concepts. Now let's synthesize and integrate the concepts that the final exam loves to pit against one another.
Reinforcing those universal patterns required for clinical reasoning across all the pediatric age groups.
Let's start by differentiating the cognitive stages, a focus on PHA.
The exam frequently uses patient statements to test which cognitive stage a child is in, and therefore what type of explanation or intervention is appropriate.
We need to distinguish 3 key types of reasoning. First, transductive reasoning.
Seen predominantly in the toddler and preschool stages, ages 2 to 7. This is connecting 2 unrelated events purely based on proximity or sequence, not actual causation.
For example, I didn't eat my vegetables and that's why my dog got sick.
Exactly. Second is inductive reasoning, which begins in the school age period, coinciding with concrete operation.
This is reasoning from specific observations to a general conclusion. They can draw inferences, but they need a concrete basis.
Like, every time I wear my blue shoes, I win the game, so wearing blue shoes makes me win.
Third, deductive reasoning, achieved in adolescence with formal operations.
This is reasoning from general principles to specific, logical conclusions. They can handle if-then statements and hypotheticals, applying formal logic.
And let's revisit the critical cognitive trap here, the conservation trap.
Right. Conservation is understanding that quantity remains the same despite changes in shape or container. This is mastered in the school age period, but in a strict order that is often tested.
Mass is mastered first, then weight is mastered second, and volume is mastered last.
So if a child understands that the clay ball still weighs the same after it's rolled into a snake for weight, but thinks the taller glass holds more juice, for volume, they are still progressing through concrete operations.
Okay, let's do a comparison review on the power of play. Play is the child's work.
And recognizing the type of play indicates the child's readiness for group activities and their cognitive stage. We have to define the 4 stages precisely.
Number 1, solitary play for the infant.
Focus purely on self and immediate objects. Peekaboo, rattles, no need for peers.
Number 2, parallel play for the toddler.
Side-by-side activity, very low interaction. They may use the same blocks, but they are building separate structures. The goal is separate.
Number 3, associative play, preschooler.
Loose groups, shared space, shared materials like dress-up clothes or a sandbox, but the key distinction, no set rules or common goal. They might talk to each other, but they don't depend on each other for the activity's success.
And finally, number 4, cooperative play for the school-age child.
Organized, defined rules, and a common goal. Team sports, complex board games, or building a synchronized fort where everyone has a specific role.
Okay, let's talk about a universal red flag. Developmental regression. This comes up frequently with hospitalized kids.
Regression reverting to an earlier, less mature behavior. A 6-year-old thumb-sucking. A toilet-trained toddler asking for a bottle. An older child wetting the bed.
The crucial clinical point is that this is a normal, unconscious defense mechanism.
A temporary coping strategy used under intense stress, illness, or hospitalization. The child is seeking comfort from a developmental stage where they felt more secure.
So your priority action here is critical and often counterintuitive to parents. You do not scold or punish the regression.
Right, that only increases the underlying anxiety. First, you address the underlying stressor, the pain, the illness, the separation.
Second, you support the child without shaming. You allow the temporary regression and confidently explain to the parents that it is an expected coping mechanism that will usually resolve once the stressor is removed.
You do not enforce strict age-appropriate rules when the child is acutely stressed.
Perfect. Let's quickly touch on assessment principles and nursing care.
Remember the fundamental directional trends of physical growth, cephalocaudal and proximodistal. This frames how we expect motor development to proceed.
And for premature infants, you must use the adjusted or corrected age for developmental assessment, like the Denver 2, and for nutritional benchmarks up until age 2.
The Denver test is the standard tool used up to age 6 to test gross motor, fine motor, language, and personal social skills. It identifies children at risk for delay. It's not diagnostic of a specific condition.
And the ultimate goal in pediatric nursing is always linking interventions back to the theoretical frameworks.
Yes. If you see a question about a hospital intervention, ask yourself, does this choice support the child's Erickson task? Does it respect their Piaget cognitive limitations?
For example, toddler care must prioritize autonomy.
And school-age patients need interventions that maintain industry, like keeping up with schoolwork.
Finally, let's do a high-yield immunization reminder pattern.
Okay, let's nail the 3 major windows you need for high-yield recall.
Infant priority, Hep B at birth. The core cluster DTaF, IPV, high PCV starts at 2 months and repeats at 4 and 6 months. That consistent pattern is key.
4 to 6-year priority. The second round of major boosters required before school entry. Remember the acronym: DTaP, MMR, varicella, and IPV.
Adolescent priority, 11 to 12 years. Tdaps, HPV, and the first dose of MenA-CWY. And remember, the HPV vaccine is critical teaching for this age group to prevent future cancers.
And that MenA-CWY second dose is required at 16 years.
Okay, time is short, the exam is close. Let's lock in the absolute must-knows with a final rapid-fire recap.
Let's do it. Top must-know mechanisms.
Infant weight, double by 6 months, triple by 1 year.
Toddler height. Double height at 2 years predicts adult height.
Anterior fontanel closure.
Yeah.
Late, 12 to 18 months.
Myelinization for bowel control. Complete by 24 months.
Hallmark symptoms you cannot miss.
Infant. Object permanence and stranger fear. Pincer grasp at 9 months.
Toddler. Negativism, parallel play, physiologic anorexia.
Preschool. Magical thinking, centration, associative play.
School age. Conservation mastered mass, then weight, then volume cooperative play, industry focus.
Red flags that demand priority action.
SIDS prevention compliance. Back to sleep, firm mattress, no soft bedding.
Adolescent screening for SI, depression, and substance use. Remember, MVAs are the leading cause of death.
Avoiding high-risk choking hazards for the toddler, especially whole grapes and hot dogs.
And immediate, emphatic reassurance. When a preschooler exhibits magical thinking guilt, you have to dispel that guilt immediately.
Most common NCLEX traps. The summary.
Do not confuse the play stages. Know the rules and goal difference between parallel, associative, and cooperative.
Do not restrict autonomy or shame toileting accidents in a toddler. Support their independence.
Do not teach abstractly to a concrete school-age thinker. Use models.
And remember the required supplements: vitamin D daily and iron for the breastfed infant after 4 months.
You know, what's fascinating here is that Gene D is not just theory. It is the foundation of every single pediatric nursing intervention. When you see an intervention question, especially those tricky prioritization scenarios, ask yourself 3 essential questions.
What are they?
Does this choice support Erickson's developmental task for this age group? Does it respect Piaget's cognitive strengths or limitations for teaching? And above all, does it prioritize safety for this developmental stage? If it hits all 3 of those points, you are absolutely on the right track.
Use this review session. Run through your key point notes one last time, focusing hard on those NCLEX trap areas we covered, the exceptions, the timing, and the why behind the priorities. You already know the content. Now it's about recognizing the patterns and prioritizing safe, developmentally appropriate care. Go ace that exam.